Great. So yeah, good to see you all. As you'll see in the programme, you'll see my name / Mike Turner, but Mike had very kindly said he would step in if I was otherwise engaged doing something else. But fortunately for him, he's off the hook. Sorry, apologies, you've got me instead. So I'm working for WHO as a consultant, and I'm here to tell you a little bit about some of the work we've been doing to develop these procurement packs or packs of minimum commodities for snakebite. So you'll be familiar with the WHO target of halving death and disability by 2030. And we've got one of our core strategic aims, so improving access to safe, effective and affordable antivenoms. And that's focusing on 8 Central and West African countries, which David, I think, will cover in a bit more detail shortly. But there's often a big focus when we think about clinical treatment and management to focusing on antivenoms. But of course, there are a lot of other things that are really important and essential to providing good clinical care, which are often absent. So last year at the conference, I came and spoke about the piece of work we'd done developing a set of minimum health facility requirements. So again, focusing on Africa, looking at each level of the health system, what is the minimum that is required to effectively treat these patients? So not just medicines and equipment, but other things like clinical skills and competencies. So what we've been doing since we all last met is working on another supporting piece of work to develop these procurement packs, which are again focusing in on Africa, keeping in mind this stockpile program. So when we started this piece of work, what were we trying to achieve? We wanted to try and develop these packs, something that would be small, basic, keeping in mind that we're targeting predominantly the primary level of the health system. But of course, they could be used anywhere. They need to be snakebite specific, of course, although several of the items are important for managing any sick patient. We've got to think about costs, of course. It's all very well having a nice long wish list, but it needs to be affordable. So when we started, we had in mind that we would develop these 5 packs. The idea was that this would not be all lumped together as one sort of whole pack, but rather these would be separate entities, so that you can see that if you have your 20 WBCT that's done over a 24-hour period and you find that you get normal results, you might not need to administer antivenom. So you might not need to go into that part of the pack, or you might administer antivenom, but you might not have any reactions that need to be managed, for example. So we started off by developing these lists, these draft lists ourselves. So we went through some clinical trial protocols. We referred to the previous piece of work I mentioned, the minimum health facility requirements, to come up with these draft lists of what we thought should be included. I'll show you an example of one on the next slide. And we had 8 clinicians from Africa who very kindly dedicated their time to look through these, provide their comments and feedback, and we had a 2-round process to reach what we have now as our final version. So this is just an example of what we have in our pack for a 20 WBCT. We did consider whether we should do separate packs for children and adults, but felt because so many of the items were in fact the same that they should all be together. And we've just got highlighted in pink the items for targeting a child. And so if this was to be used for an adult, there'd be nothing that should be wasted or left. These would be, the pediatric cannulas would be stored and used for other sick patients. So rather than just show you long lists of what we've developed, I just thought it'd be interesting to pull out some of the discussion points that were highlighted along this 2-round process. So for the 20 WBCT pack, we've got enough commodities or items for this to be performed over a 24-hour period, and for not just the patient, but also for a control. We had some discussion about what would be the most appropriate type of tubes. The BD vacutainers were also proposed, but these are more susceptible to variations in changes in temperature and also in terms of the sex of the patient. We also found clinicians were just more familiar with using the soda lime vials. So it was best to stick with that. They also helpfully have a flat bottom, so you don't need to include a rack to pop them in. There was a suggestion about whether we should include the vacutainers for lab bloods, but actually, again, thinking that we are keeping in mind the primary level of the health system, there will be many patients or many facilities that don't have access to lab bloods, or indeed you won't get these back perhaps in a timely fashion. So those were not included. You might wonder why I've put tetanus in this section, because clearly giving tetanus toxoid is not part of a 20 WBCT. But we had thought this would be really important not to miss and to pop in somewhere, and that perhaps this might be the best place to shoehorn it in. However, it became clear there was no lyophilized version of this, and it does require a cold chain, and none of the items in any of the other packs did require a cold chain, so we felt actually best to remove this. But what we can do is reference it in some of the material we could include along with the packs to say, this is important, don't forget it, but it's not actually going to be an item that we would include in the pack itself. Then we've got the administration of antivenom itself. So we've got adrenaline for pre-medication. There was some lack of consensus about what the appropriate dose would be for a child. So we agreed to just, in our usage documentation, say as per local protocol. We had also included in this section fluid management items. So, for example, a bowl with gradation marks, you could measure how much someone has vomited, or all the items you would need to put a catheter in, so you could measure someone's fluid output. But again, this was becoming increasingly a large pack with lots of items, and we decided to remove this. Of course, it is important, but not to be included in this section. We did include the fluids themselves. This was also another point where there was some discussion about what would be the most appropriate fluid to include. Originally, normal saline, 0.9%, was proposed, and this was also because if you have patients with acute kidney injury who are susceptible to have a raised potassium or hyperkalemia, normal saline doesn't include any extra potassium. However, there is increasing body of evidence to say actually giving Hartmann's solution, which does have extra potassium in, it is a good option for patients with AKI, and it doesn't increase the risk of hyperkalemia. And there's downsides of giving normal saline. It can contribute to a metabolic acidosis, and Hartmann's is actually the most physiologically similar fluid to blood. So this was changed to Hartmann's. And we've also got 2 litres of dextrose for children. So you note we had 5 packs originally. We actually decided to remove completely this pack for managing neurotoxic envenomation. We had wanted to include the drugs, the essential drugs to manage this. But again, with looking at the feedback that came back, this became a very long list of items. So it was removed for 2 reasons. Number one, it was an increasingly long list of items, because as clinicians rightly said, fine, we can have the drugs, but what about all the other things you need to manage an airway? All the other equipment? You know, we would like a Goodell, we would like a laryngoscope, an ET tube, etc. And someone even said they would like a ventilator, which I think is quite difficult to put into a small pack. And then we had some discussion about all the different medications that could be included, and people were familiar with or wanted to use different things, and so there was a lack of consensus on the drugs themselves as well. So we felt it perhaps did not fit our brief of coming up with a basic pack. Then we had the management of immediate reactions to antivenom. That covered those 3 areas: allergic, pyrogenic, and anaphylactic. Someone suggested, well, what about adding in management of late serum sickness reactions? But again, often you don't see these patients because it happens a bit later and they've been discharged by this point. So we agreed that we would focus on just the immediate reactions. And then lastly, we have our snakebite wound care kit. So we've included items for cleaning, aspiration, and debridement. Again, it wasn't for us to say when aspiration or debridement should be done. It was down to the clinician who has got the patient in front of them. And that might depend on the size and location of the blister, the contents, is it full of blood? Is there a coagulopathy present? So we felt that was not for us to say. They've got a number of different dressings in there, ranging from different sizes to also different types, so including honey or silver, if there is infection present. And yeah, there's sort of different dressings to accommodate different amounts of exudate that is being produced by that wound. We didn't want to include antibiotics, although that may be indicated for some patients. We did not want to contribute to people sort of just giving antibiotics for every case. So we have our draft lists now. We'd like this to go out for external consultation so that others can also provide their comments and feedback. As I alluded to, we also have the opportunity to include some other material alongside or in these packs, a chance, I suppose, to do a bit of education or and whilst we didn't ask our clinicians directly what would you like to be included in this extra material, there are a number of items that became apparent through going through this process about what we could include. So fluid balance and management, of course, tetanus. We've now not included tetanus toxoid, but again, prompting people to think about it. Perhaps an algorithm for anaphylaxis. And there were suggestions for including some sort of images to show how you might administer a splint or set up an IV giving set. And now we need to go on to develop a procurement partnership to get this up and running, and also go through and think about the costs associated with each of these items. There'll be some items where we have a specific brand that has been suggested, but for others it's more generic. It'll be a case of looking at the costs that go with that. And it is possible that we might be able to go on in the future and develop other regional specific packs. So I hope I've kept to time. Thank you very much to the colleagues who contributed to developing this and giving our feedback to us. Thank you to my WHO colleagues and also to Wellcome for funding it.